I don't know how they turn the lights on. I assume they do that up there.
Good evening, everyone. Thank you. Thank you. Greetings and welcome to our live audience and those who are viewing via the live stream to a panel discussion centered on International Overdose Awareness Day. This event, sponsored by the Columbus Dispatch, called Columbus Conversations. What is the state of the opioid crisis in our community? The opioid epidemic continues to be a critical health issue in Ohio, with Ohio now ranking fourth in the nation for opioid related deaths. Stigma around persons who use substances reduces the community's acceptance of strategies for persons who can have their lives saved, such as using harm reduction strategies, which we know has been proven to prevent overdose and poisoning deaths. International Overdose Awareness Day was started in 2001 and aims to raise awareness about the risks of overdose, educate persons on how to intervene when witnessing an overdose, and offer family, friends, and communities a space to honor, without stigma, their loved ones who have died from overdose. Ohio State University is a proud sponsor of this event, specifically because opioid addiction is a community and family problem. Many of our faculty and staff understand the importance of prevention, treatment, and research, such as our OSU Extension offices, which are in all 88 counties, and steps up to address prevention in each of those counties and communities. Ohio State University Wexner Medical Center is also a proud member of the Ohio Opioid Education Alliance. Members and Members and faculty and staff of Harding Hospital partners with Office of Student Life Student Wellness Center, Real Student Health, Counseling and Consultation Service, Recreational Sports, Student Advocacy, and Disability Services in providing comprehensive care, outreach, and services to support our diverse student population. I will now introduce Edwina Blackwell Clark, the new editor of the Dispatch.
Good evening. Good evening. It's good to see everyone. I'm just here to welcome you to our community conversation series. Amelia Robinson, our opinion and community engagement editor, started this series about a year ago. But we're excited that today is the first one in person. So that's right. That's right. So it's lovely. It's just really great to see everyone out. What this series and this particular program is also being broadcast live on dispatch.com, on our Facebook page, and also on our YouTube channel. I want to say thank you to our sponsors, who are the Central Ohio Hospital Council, the Ohio State University, WOSU, Public Media, and the Dispatch, dispatch.com. It's really, from my perspective, it's really important that we do this and have these conversations in the community. Our role is not just to report on the issues, but also be a convener of the voices of the community. Also take a role in what it looks like for the solutions. So I'm hopeful that after you hear the panel, our distinguished panelists talk tonight, that there will be some real conversations. We're excited that we can use our platform to reach others who are not here, but who need to be involved in this conversation as it relates to the opioid crisis in our community. So thank you very much for coming and welcome. And I'd like to introduce you to Amelia, who will take over from here. Thank you.
Well, thank you, Edwin. I appreciate that introduction. And like Edwin has said, these conversations are really about things that are important to the community. So if you ever have an idea about a topic, feel free to reach out to me. I want to thank you all for coming out in person, and for everybody who is watching on Facebook, Twitter, dispatch.com, and YouTube. After the program, these will be rebroadcast on those platforms. So if you want to go back, you want to share something with people in your circle, feel free to. It's going to be some good information shared today. We have a fantastic panel. Let me just tell you that, first of all, going off. This is one of the best panels I've ever seen. Not only are they good looking, but they're real smart. You can just tell. I'm gonna introduce them, and you're gonna tell in just 1 minute why I'm so excited about Erika Clark-Jones, who is CEO of ADAMH Board. Next to Erika, we have Brian Pierson from Mount Carmel Health System. He is the Regional Director of Outreach and Population Health. We have Andrea Boxill next to him. Did I say that wrong? Boxill?
I've been called worse.
Me too, hon. Believe that. I've been in media for 20 years. I've been called a lot worse. Okay, she is from alcohol. She's the Administrator of Alcohol and Drug Services for Columbus Health Department. Next to her, we have Dr. Emily Kauffman, who is an emergency medicine physician at Ohio State University, Wexner Medical Center East. And to my left, we have Juliet Dorris-Williams, who is Executive Director of the P.E.E.R Center. And she was a big star in our video there, so yeah. We also have Erin McKnight, who is Nationwide Children's Medication-Assisted Treatment for Addiction Program Medical Director. We have Dr. Krisanna Deppen, who is OhioHealth's Grant Addiction Medicine Fellowship Program Director. And next to Krisanna is the one who has the easiest title of all, Captain Matt Parrish from the Columbus Fire Department. So give him a big hand as well. So the first question, obviously our program is called, what is the status of opioid addiction and the overdose crisis in our community? I'm wondering what is the status, and also why are we considering this a crisis? You want to take that one?
Technology. Yes, hello, good evening. Technology. Thank you for the first question. I first want to say thank you to everyone who is here, because this is such a complex topic and it takes a lot of hard work and dedication to these patients who are struggling with this chronic brain disease. We need all the help we can get. It is not an easy area to work in. So I want to first extend a thanks to all these fantastic people on this panel. So the overdose crisis and the opioid epidemic, I mean, this isn't new. It's hard to capture interest to, capture folks' attentions because it's been going on so long. We're probably well into 25 years into this crisis, and it seems only that things are getting worse. And, this is a whole discussion about pain management, pain pills and whatnot, but what counts right now is the drug supply is getting exceedingly dangerous. And there are more people dying because at this point, fentanyl is pervasive. Fentanyl is pervasive in the drug supply. People do not know what they're getting, whether they have developed a full substance use disorder, like opioid use disorder, or whether they're just have intermittent use. They are at extreme risk of death. It is a very dangerous time to use, and we want to keep people safe. And unfortunately, we're hoping our numbers have plateaued because we're getting great people that are here on this panel to help with this, and we have evidence-based treatments to really help folks that are struggling with this chronic disease. We want to keep getting attention of people in the community to keep helping with this and recognizing it and getting people into treatment.
Now, this is a question for you, Captain Matt. As somebody who works in public safety, what is the opioid crisis like for you, and what role do you think public safety should play in this whole crisis?
Well, thank you, and I too appreciate being a part of this panel with a lot of folks that I've worked with for several years now, and it's might be too close, but I think public safety plays a really important role in the opioid epidemic, and we are the ultimate safety net. When people need help, they call 911. And, when we started this journey and really addressing it from a public safety approach, we had one goal in mind, and that was preservation of life. How do we keep people alive to get them to that next chance, that next step? And, with a lot of support and help from Columbus Police, Commander Dennis Jeffrey, who's now with OSU Police, and OSU is really going to benefit from his experience, we launched a Narcan pilot. And over that period, law enforcement has saved thousands of lives and given folks thousands of chances at recovery. More importantly, too, is we've really helped to be a part of that continuum. Like you said, not one person's going to do it alone. So it's, where public safety fits in is in that continuum of getting folks to that next right step. We can go to a scene and revive somebody, but if we don't take them to the right place in the right amount of time, they're not going to get the help they need. And the other thing I've realized in this journey is that our data, I think that public safety data is the most real-time surveillance of the health of a community because we see everything. We see the stuff that goes to the hospital and doesn't go to the hospital. And we'll recognize a problem or a shift in the drug supply or the potency well before the hospitals will, well before public health will. And by building these partnerships, we've been able to, get the right information to folks to do outreach and harm reduction. So, and then going beyond that, after the safety net is we've really started to focus on some specialized teams. We created the REACT program, a multidiscipline team where we encourage folks, we address their barriers. We really will help shepherd them through that process. And if they slip up and fall again, we're right there to catch them and get them back on that path.
So Juliet, this question is for you. This is something I always kind of wondered about. So we had a column in today's paper from the coroner who said that 89% of the overdose deaths were connected to fentanyl. And obviously fentanyl is a very dangerous drug. And you wouldn't think that people would sell something to their clients, that they knew was dangerous. What do you think the connection is to that? And also, as far as why would somebody sell a dangerous drug like that to a client? And also, are opioids the only thing we're worried about when we're talking about fentanyl overdose deaths?
So my answer is, why are we focused on the middle guy? Have you seen our economy? Why are we focused on him? They didn't make it. They didn't bring it into our community. They're trying to make a living. So we're focused on the seller, versus focusing on the criminals that are actually bringing it into our community. They don't know what they've got. They didn't make it. And yes, the folks that they're selling it to, that's some risky stuff. It's risky behavior. But the focus is in the wrong place.
Thank you, and I think you're so right. And I think throughout our history of addressing substance use disorder, whether it be drugs or alcohol, we continue to get caught up and play this game of, well, how are we going to address the person who's using it? They are making choices. We're so rooted in religiosity and morals of the choices they're making versus understanding the disease factor and the progression of the disease, but then also the economic factor. And the economic factor is the greatest risk in the progression of drug use. When they say, what are the gateway drugs? I used to say being poor, being Black, being female, everything that already has you gerrymandered outside of society. So when you consider, why would I market to you something that could potentially kill you? Well, I could also turn you out and make a lot of money. I could also give you the best high that you've ever had. Why do we go from Coke to Diet Coke to Cherry Coke to Vanilla Coke? Well, because they're marketing. So all I'm doing is marketing, much like Eli Lilly, much like Merck. But because I'm doing it with a criminal element involved, it's not perceived in the same vein, when in reality, all I'm trying to do is expand my market. I'm trying to support my family. And unfortunately, that may be at the cost of your loved one's life. So will the person who dies from diabetes or cancer as a result of smoking. Unfortunately, people are going to die. It just so happens during this crisis, the degree to which we've seen it and the extent to which we've seen it, it still doesn't resonate with people. If I say 1 in 5 people die every 10 minutes of a drug overdose, if I say 107,000 people die, if I say a 737 goes down every day full of people overdosing, it still doesn't hit people. So I think, to your point, it's kind of, we tend to focus on one thing instead of focusing on all of the dynamics that play into the complexity of the issue.
And since you have the microphone, is it just opioids that we have to worry about, or can you talk about that a little bit?
No.
I didn't the answer, but I thought
so it's really, and you know what, I've actually been approached about this because we have on the Columbus and Franklin County addiction page, we have an ad that says marijuana can be laced with fentanyl, period. Fentanyl can kill you, period. Well, there are some in the community who say, well, that's not necessarily true. Actually, it's not an either or, both statements are true. I can put fentanyl in marijuana, and if you bake it at a low temperature and turn it into an edible, I can also potentially kill you. We also have it in methamphetamine. We have it in cocaine. We have it in heroin. We actually have cap pills, press pills that are distributed to look just like the pharmaceutical pill of Percocet or whatever, which is why we distribute fentanyl test strips. Everything needs to be tested.
Now, so we have a reader named Jackie who asked a question about, she's actually raising her 7-year-old granddaughter because her son is battling opioid addiction. What kind of resources are there for people who are taking this on the front end and, long-term raising children and dipping into their savings and doing that sort of thing to help their family get through this crisis? Like, what kind of resources are there for them?
Good evening. So just a little bit about ADAMH, or Franklin County's Alcohol, Drug, and Mental Health Board. We're often the silent partner in a lot of the work that the folks here on this stage and in the audience, and actually in our viewing audience, we support them. ADAMH gives funds to all 16 school districts here in Franklin County. And we do that for prevention, for example, in each of those school districts to make sure kids are aware and have the education about resources, one about education about drugs, and then resources for their parents, how to get help, how to get into treatment. And so that's available to any public school student in any one of the public school districts here in Franklin County. And we dedicate about 26% of our budget to these activities, which is about $30 million going to prevention activities. So we think it's really important that families have the connections to the resources that they need. I'll pause here and go to our colleague at Nationwide Children's Hospital about how you help families as well.
Let's see if we can do this without the feedback this time. So at Nationwide Children's, our program that we have is really a multidisciplinary, comprehensive program that is helping adolescents and young adults with substance use. And so this can encompass someone on their trajectory of substance use from initially starting to use nicotine to dabbling and experimenting with a variety of substances, placing them at very high risk for overdose, to having a diagnosis of an opioid use disorder. We care for these adolescents within this really tumultuous trajectory of their life, starting from about age 14, all the way up to, we honestly have some patients who are nearing 30 within our program, just because it is such a tight group of people that help navigate all of those life changes that happen during that young adult time frame, from graduating high school, helping someone obtain a GED or talk about what their education or employment opportunities look like, helping people find stable housing, helping those who have had children or maybe who have had their children taken away, figure out how to parent, get those resources so that they can do that effectively and reunite their families. This is not something that we can do in isolation, and we really look out to all of our community partners as well as partners within the different counties of where our patients are served. Our patients come from a variety of places in Central Ohio as well as Southern Ohio, and so we have to do a lot of digging based off of where they live and what their resources are. I will say that our social work team is paramount in figuring out how to make sure that these socioeconomic needs are met and the determinants of health that we can't necessarily put a finger on are really addressed at each visit. And it's only within then that we can really make sure that our patients are cared for and that they're able to thrive in their lives and that they are able to really see what not using, what recovery can look like for them, and how they can really enjoy their life. Because just not using drugs or abstaining from something doesn't necessarily mean someone's truly in recovery. They really need to be able to live their life to their fullest, have a job they love, have a family that they feel that they're supported by, have relationships that they feel they're fulfilled by. And that is something that when you start using as an adolescent, you lose the ability to navigate those things. And our team helps people do that. And it's probably part of the reason why it's really hard for us to say goodbye to them, is because they very much get used to being within our confines and being within our group and figuring out how to navigate that. I will say that the resources that are available all depend on the county of where our patients are at. And it all depends on the funds that are there and things like that. And so we really have to dig deep based off of where everyone is in order to figure out how best to help them.
You know, speaking of children, how is addiction different in children than adults? And what are the risk factors that are different for children versus adults?
So we know that substance use disorder is actually a pediatric problem. A lot of people don't want to say that. They don't want to think about that. It's uncomfortable for pediatric providers to think about that because they want to think about babies and little kids and really forget kind of about the teenage population and all of the things that go into caring for that population. It is uncomfortable to talk about drugs with teenagers. It's uncomfortable to talk about sex. It's uncomfortable to talk about those really difficult topics that affect our youth. However, we know that the longer you delay your onset of initiation of substance use, the more likely you are to not have a substance use disorder. So it is our job as providers and as communities, as schools, as parents to really help delay that onset of initiation of any kind of substance use as late as we can. And by doing that, we help protect those youth from developing a substance use disorder. Now, I will say that that does not mean that adolescents are not going to use substances. It is a time of experimentation. That is a developmentally appropriate thing to do during adolescence, is to experiment with a variety of things. We hope that it's not necessarily going to be experimenting with the drugs, but that does happen. And so when this does happen, it's important to talk to adolescents about what does that look like and how to keep them safe. We do know that this time of development for teenagers is one of the greatest times of brain development that you can have. And so if we use substances during this time frame, you actually halt brain development really kind of at the initiation or that time frame of when you started using it. And so this can be really perplexing for someone who might be working with someone in the adult sphere who's maybe 21, 22, and they have had a long history of substance use and they have difficulty following up with their appointments. They have difficulty really making to things on time. They have difficulty understanding what you're trying to say. And then you look back and you see, wow, he started using marijuana at age 13. Well, he's developmentally really more in that early adolescent time frame. So you're trying to interact with someone at a 21-year-old level who really can't comprehend things in that sphere and really needs to comprehend things more at the 13-year-old age range. And that is a really big barrier when giving adolescents and young adults treatment for substance use, because the way they access the system is different than the way an adult accesses the system. And that might be someone who's over an 18 who's trying to access the adult system has a very difficult time trying to do that for treatment services. We also know that the way adolescents use substances, specifically when you're talking about opioid use disorder, and specifically when we're in this crisis of fentanyl in our market, that adolescent overdose has actually dramatically risen since the pandemic. We doubled adolescent overdoses nationally from 2019 to 2020, and that continued to rise into 2021. Now, adolescent opioid use did not increase as far as the amount of teenagers who were new initiators of this did not increase. It was all due to the drug supply. And adolescents aren't seeking out illicit fentanyl. So there are some that I do care for who have opioid use disorder and are seeking out fentanyl to inject or things like that. But the majority are looking for pills. The majority are looking for prescription opioids, Vicodin, Percocet, benzodiazepines. They're looking for Adderall. They're looking for a variety of different types of pills. And how they access it is they buy it online. They get it from friends, or they find someone else who can give them access to this medication. We've done a great job at decreasing the amount of prescriptions we're giving to people. And so really what's left out there in the market is mostly pressed pills. About 1 in 3, 1 in 4 pills are pressed with illicit fentanyl. These teenagers could just choose one pill one time to experiment and overdose and die. And that is how our adolescents are dying from overdose right now. They're not dying because they're seeking out heroin or they're seeking out fentanyl. They're dying from that first use where they didn't know what that pill was going to be. And so while harm reduction is a controversial topic for some, even more so in the pediatric age range, it is dangerous and deadly to not have those conversations with teenagers about what to do if you're going to use a substance, what an overdose looks like, how do you protect yourself from it? And those are very different conversations about how to do those things than I have with someone who has an opioid use disorder, has overdosed maybe in themselves in the past, has seen a friend or a family member who's overdosed, knows what it looks like, knows how to use naloxone, than a teenager who's maybe starting to dabble in substances here and there, who has no idea what that landscape looks like, does not know what an overdose looks like, does not know about naloxone, does not know about fentanyl test strips. And so those are very different conversations to have to make sure everyone's protected.
Yeah, thank you for that. That was great. Now, Brian, obviously during the pandemic, we had a lot of conversations in the community about the emergency rooms and the hospitals in general and some of the stresses that were put on hospitals as a result of people not taking the pandemic as serious as we probably wanted them to. What has been the impact of the overdose crisis on hospitals? And in general, what might be the long-term impact of the crisis?
Yeah, thank you. So before I jump into that, I will say one thing that I think it's important to note. The folks on this panel, we all represent different organizations and we all do different things. We all do a lot of the same things, but we also do a lot of different things. And when we came here this evening, after a lot of us hadn't seen each other for a while, face to face, what was apparent is this: we all know each other. We are all working together in Franklin County. I think that's a blessing within Franklin County. You've got a unified approach to how we're going to help manage addiction in general, because it's so fluid, it changes continuously. So just wanted to start with that. Hospitals have really been challenged on a number of different levels as it relates specifically to addiction and all things COVID. First, for probably 2 years, we struggled just to take care of people who were dealing with COVID. And so many different things were put by the wayside, not because we wanted to, but because the crisis required that of us. So now, as we get back to looking at all of the different things that we have to do to make sure we keep the entire community healthy, we're having these conversations, which is fantastic. And it's important to note, getting back to the first question, it was, why are we here? Why are we having this discussion? And we're having this discussion because addiction is permeating every socioeconomic sector, every population within society. We know that. We also know that, like every other or many other chronic diseases, addiction is also serving, or there's a disproportionate impact on those who are vulnerable. And I think about the definition of vulnerability, and addiction in and of itself creates an extraordinary vulnerability. So some of the ways that we have tried to address those things through COVID and post-COVID, and really at Mount Carmel for the last 30 plus years, is making sure that we're following people and taking care of them where they are, paying attention to the most vulnerable, and making sure that also we're addressing things like knowledge deficit. Knowledge deficit is an enormous struggle. Think about this. Addiction is a very complex disorder. We also know the literature shows that between 39 and 45% of people dealing with active addiction also have a secondary mental health disorder. So that just ramps up that level of complexity. Now, as we work with people, we know that when they're struggling to figure out where they're going to be housed, where am I going to pay my next rent payment, where's my next meal coming from, and then we're trying to add in the complexity of treatment for a disorder, a brain disorder, like substance use disorder, and maybe a co-occurring disorder, like another mental health disorder. They require total focus from an individual. So some of those complexities, hospitals have been dealing with those complexities before COVID, during COVID, and after COVID. So one of the solutions that we found, I guess a couple of different things, but one thing that we've really found, in addition to programs like our street medicine program that has been functioning for quite a long time, and looks at the biological, psychological, social, and spiritual needs of all people who are dealing with substance use disorders, severe and persistent mental health disorders, and others, is the addition of peer support personnel. The clinical component is extremely important, but one of the barriers that we find is trust. And to get beyond that trust, or the mistrust, I guess I should say, and the fear that might keep people from entering treatment, a long-term treatment plan or a short-term treatment plan, is getting beyond that. So using peer support does a couple of different things. These are people who have lived experience. So they can cut through some of the crap that a clinician may not be able to. They can get that trust, they can gain that trust. And then we have developed, at least our program, and peer support really is about developing long-term relationships. So in order to manage keeping people in treatment, because one of the barriers also is relapse and people leaving treatment before treatment really is going to be part of the rest of their lives. We need to make sure that when someone relapses, and they will relapse, that we have someone there that's going to help them through that and get them right back on their feet and get them back into whatever treatment they need. So it really is a complex tapestry of different things, but it really boils down to making sure that we are developing trust and that people feel safe and comfortable moving forward.
If you don't mind, I'll just jump in on this because I think a lot of the points that Brian raised, as well as others on the stage, are really important here. And to me, that trust, the accessibility, regardless of your circumstance, if you're uninsured or underinsured, is the reason why we have a network of community-based providers. ADAMH funds 30 different community-based providers in all areas of Franklin County, because after you've interacted with the first responder personnel, and after you're treated in the hospitals or you've had outreach from Andrea's team or other teams that are out there, you have to stay in relationship with your provider. We want to keep you in recovery. We want you to have access to recovery housing, things that address those social determinants of behavioral health, mental health, and addiction, so that you can stay connected to a support network. The availability of peers to be available to you. We fund Juliet's program on the east side and the west side because we want to make sure people have a social connection. We want to decrease social isolation, increase social connection so that people stay in recovery. Again, I said I was the silent partner. It's really a point of pride, and I have some board members even here joining us tonight, but this is why ADAMH exists. We are funded through a tax levy here in Franklin County, and through the generosity of the voters, we just had a recent increase, but now you see why, because the times demand it. We need a strong behavioral health safety net, and ADAMH funds all of these activities from outreach, recovery, housing, prevention, treatment. We know that it works, and that's why we're here for you.
And I want to add one thing to that, because specifically from a hospital perspective, we are always trying to deal with the complexities of these disorders, up to and including how they get paid for. So the importance of what Erika just described can't be overemphasized. It's not just about, is a person insured or are they not insured? Is the person on Medicaid? Are they on Medicare? Are they on traditional Medicaid? Are they on managed care Medicaid? Is it a private insurer? All of these things will dictate the kind of care access a person will have. And frequently we're working with people who don't have access because there's economic barriers. ADAMH does help many of the people that we work with access care that is as good as the care that anybody else is receiving in the community, because they're receiving it in the same places. And it really is, it helps reduce that hurdle to access to care.
I just wanted to add a bit more to what happens in the adult healthcare in the health system and how that has been impacted from this opioid overdose crisis. So between EMS and the community resources live us. And one of the things that we are noticing in the hospitals is that, especially during COVID, patients are presenting sicker from their disease of addiction. One of the things, unfortunately, is that overdose is the tip of the iceberg from where we sit. We are seeing young, otherwise healthy people presenting with heart disease or infections in their blood and skin infections that on our team in the hospital, we've started using the term end-stage substance use because some of these people end up on hospice. And so we want to do what we can in the hospital to care for these patients so they don't end up so sick. And so I think the prevention that you've spoken about is so important. The other component I would say, and I want to say this from a place of many of us here educators and want to start teaching. Right now, if someone presents with chest pain from a heart attack and they go to Dr. Kauffman's emergency department or any emergency department across the country, they will get the same standard of care when they walk in the door. If someone presents with an overdose or a heart infection from addiction, I can't promise you that same care. It depends on where they are in the country, which hospital they are going to, which doctor happens to be on shift at that time. And so one of the things that is really important in the healthcare system from where I sit is that we need to standardize this work so that no matter when your loved one comes to my hospital or any other hospital, they will get the right evidence-based care to treat their disease.
Yeah. We're getting the hang of it.
Thank you for saying that. Yes. I think a lot of our struggle, and I wholeheartedly agree with what Dr. Deppen said, patients are sicker. Since COVID, they are sicker. And it's not just substance use, it's many other disorders. But people are presenting with multiple substances. And so we're in a position we're trying to figure out if they're getting hospitalized, what are we treating first? The alcohol, the opioids? Oh, maybe they're using stimulants recreationally too. These are complex patients. But what we are coming from the healthcare provider standpoint and what I interact with and my partners down there from OSU who are part of my great team, we are trying to convince other providers, nurses, techs, aides, patient registration, they need to care about this disorder. This is a disease just like heart disease, right? This is a disease that we need to be rallying around these patients. These are difficult patients to take care of. We know they have complex needs like we've all talked about. We run against an attitude where everyone still seems to think this is this moral choice. Somebody's chosen this lifestyle. Nobody has chosen this lifestyle. This is a disease that we can intervene. There are evidence-based treatments. We can put them on the path to recovery. If they're not willing to engage with us this day, they need harm reduction treatment. They need harm reduction. I love you enough. I want to keep you safe. I don't want you to die. And that's what we fight against every single day in the department. I work in the department. I've made some headway, but it's a hard job. And I'm just one person in the emergency department. I'd like to think that we've had slightly less stigmatizing language that we hear, but we're convincing providers to take care of what is a chronic brain disease that is evidence-based, that all physicians learn about, but there's still so many people who dismiss this. And so this is what we fight against.
And
Sorry.
that kind of brings out something Andrea said in one of the videos we have on DaytonDispatch.com. The idea that the human element is removed from the conversation when you're talking about substance abuse. People don't think in terms of human decency. What can we do to change that?
So, I think, first of all, your videographer was great, like at making you feel comfortable. And I started like getting on my soapbox.
I think we like you on your soapbox.
Well, the soapbox piece for me is the lack of human decency is not just about how we treat people with substance use disorder. We treat each other poorly across the board. And I think that COVID definitely exacerbated that because we isolated, right? So there's this whole existential conversation we can go into as to how we progress to this point. But at its base, one of the things that you just talked about, Dr. Kauffman, I was just at the health department, we were doing, so the Columbus and Franklin County addiction plan, when you said it's like a reunion for us. So we have an addiction plan that we are all members of. So we have a strategy and an approach, interventions based upon evidence and looking at outcomes and implementation across every sector. So I was just there, and one of the mothers, if I start crying, I think I shared this woman, the Addicts Parent United was there, and they had 7 banners of 8 layers, 30 people across, of photos of people who had died from overdose. And so I was going up introducing, saying, thank you, thank you. And I went up to this woman and her husband, and I said, oh, are you here for the Addicts Parent United? So happy, da, 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 da. We're here to uplift your child, not demonize their death. When did your child die? She broke down and said June. And when I say broke, she like broke. And so I went to hug her and pick her up. And she said, do you know people don't even ask me? And so I think culturally, we have all gotten away from being decent human beings. to say that I care for you, though I don't know you, because I am, because you are. If you don't exist, I don't exist. And we've gotten away from that teaching, right? I can walk in here today and have reunion with people I've worked with, I've served them, I've had that privilege. And so I have to acknowledge them and say thank you. At the same time, we don't even say thank you anymore. So if we're going to figure out how to get back to human decency, we have to call it out. And we have to call it for what it is. And we have to hold each other accountable. And that doesn't mean being combative. It doesn't mean being disrespectful. It means putting things in very human terms. So when you talk about the emergency room, what this mother then said to me was, I got to be careful. I will never go back to such hospital again with my nephew. Why? They were absolutely horrible. Within 20 hours of his psychotic episode on meth, they released him. They wouldn't pink sleep. I mean, she went through. So I said, well, let me get you in contact with Jeff at the hospital. So, because I know they're trying to figure out that standardized practice that isn't just based upon medicine and evidence. It's based upon quality of care and relationship with the patient.
Does anybody want to add anything else to that, or? Well, we kind of throw terms like recovery and substance abuse around a lot. What exactly is recovery, and what do you wish people knew about substance abuse that they may not know?
I'm gonna pass this off because this is her area. What I will say is one thing that we've continued to focus on in this conversation is the disease of addiction. But do know that about 30% of those who overdosed and died would not qualify as those with the disease of addiction to get back to the accidental overdose.
Recovery is a process of change. It's as simple as that.
You're done.
There are lots more words, and I'm usually a person of few words. Some people would disagree, but it is a process of change, and it does not. It's not about addiction. It's not about mental health. It is about your life and the goals that you, if you have any, you want to develop some. What do you want to do with your life? But it is a process of change. It's very simple. And when, as a person in recovery and long-term recovery on the mental health and trauma side of things, we come to, in the addiction world, folks talk about reaching rock bottom, and I don't know that I necessarily agree with that phraseology, but I do agree with coming to the bottom of yourself. When you are sick and tired of being sick and tired, and you're looking in your rear view, and you see destruction, relationships, jobs, life, whatever it is that you're seeing behind you, and there's all of these different situations and circumstances that you've been involved in, and you are the common denominator. You are the common denominator. And so when you get to that point, it's okay, it's getting real with yourself. And it is, when you're getting real and you get authentic, you show up. I've heard one of my colleagues talk about surrendering to yourself. Choosing yourself. And when you choose yourself, it's sometimes that means you have to choose to separate yourself from other people and other situations and other circumstances that feed into a life that you don't want anymore. It's making a different decision.
That was more than just one word. So I appreciate you expanding out a little bit more. Thank you for that. So we have, if you guys have questions, Jeff has some index cards. We're going to try to take, and so this is Joanna on this side. So we're going to take some questions from the audience. as well. But I wanted to ask. Okay, you want to add? Okay.
No. Before you ask, we just wanted to mic over here.
Okay. I was going to ask, I had a couple questions from folks about this. How are people who are actually in recovery represented in discussions about solutions to this problem?
The green light's still on, so I'm good to go. So in preparation, I wanted to make sure that when I was sitting here on a panel, that I was going to be able to speak intelligently about the subject at hand, right? I certainly don't know everything. So what I chose to do is meet with one of our peer supporters, and she is, I already got permission from her to say her name. So Karen Otto, she's amazing at what she does, and she has lived experience. So I did that intentionally because I wanted someone with lived experience to inform me so that when I sit here, I can help inform in a way that is meaningful. One thing that she shared with me that I thought was meaningful, and again, I got her permission to share this as well. She mentioned, as she was talking about her process of recovery, and she is currently in recovery, she said even when she was in treatment, and she's one that was dealing with dual diagnosis, she said that I kept using until I started to address both my behavioral health and my substance use disorder. And to me, that was just, I mean, clinically it makes sense, but to hear it from someone who's been through it, it helps inform how we approach the care of others moving forward. So I think it's just as simple as that. It's about sitting down with people who have lived experience, making them part of the planning process, making them part of the recovery process, helping them or allowing them, empowering them to help us build a system that works for everyone. One other thing that happened, and this is just in the last 24 hours, this was last night for 2.5 hours, I was on a conversation, I had a conversation with a colleague that I've worked with in the past who's going through this right now with her daughter. And she was describing her experience and was lost in the experience. And as I was listening to her, and she was talking about her daughter's experience right now, there were several components of that I didn't even know how to respond to. I didn't know how to help her. So until all of us who are helpers have a process that we all feel comfortable with at any given time, and we know how to get somebody linked appropriately at any given time, we're going to continue to struggle. So I think people in recovery can help inform us in that space.
I can't help but take advantage of this moment to talk about the forthcoming Franklin County Mental Health and Addiction Crisis Center that is planned to break ground here in the next 3 to 6 months and be completed by the end of 2024. And it really is taking the best thinking from the experts in our community and persons with lived experience. Captain Parrish, Juliet Dorris-Williams, they all sit on this advisory group and persons with lived experience as well to say, here's what we want our experience to be. If a loved one experiences, has a substance use disorder, or is in crisis, and we present either at the emergency room or at this crisis center, here's what we expect to happen, right? From the stabilization period, but then upon discharge, who am I linked with? Am I linked with a peer? Is someone going to walk alongside me? So we're embedding all of that information into the programs from the forthcoming Mental Health and Addiction Crisis Center. And Amelia, I don't know if we're going to talk about this, but I don't want to miss the opportunity also that Andrea brought up about saving lives. I think it was within the last 6 months here on the campus of Ohio State University, we lost 2 students here from overdose. And I'm sensitive to that. These students were 21 and 22 years old. I'm a parent of individuals that age, and I can't imagine what those families are going through. One of the things that we did with our state opiate response dollars, they're federal dollars, they come through our Ohio Mental Health and Addiction Services, and they're distributed in every county, but we get to decide, our county gets to decide. Persons with lived experience help inform how we use those dollars. And one of the things we've invested in is called, it's a naloxone box. And essentially it is a low barrier way to get naloxone. And for individuals, once they change their heart, right, and overcome the stigma and say, I'm going to help here, What we do is we install these nalox boxes in common places so that everyone can assist in saving a life. And it's very easy to use. As a matter of fact, Michaela Elliott is outside right now at our ADAMH table, and there is a demonstration of these boxes. But we've put these boxes in every Columbus Metropolitan Library. They're currently in 16 recreation centers. They're at every COTA Transit Center. And we've got 70 in the community now, 200 are planned by the end of next year. 80 are uncommitted still. So if there's anyone in the community at churches or anywhere, then they want a nalox box installed, you can do that. But with the 70 that we've installed over the last 6 months, we've had 3 reports of lives being saved, of people intervening and bringing people back in the library, between the stacks, at the bus stop. So we know that it's working in terms of saving lives, and that's just us. I know all of our partners have a Narcan distribution plan, and I know that OSU, we are actually going to install 20 nalox boxes here on the campus of OSU here in the coming months.
I think, to language and how you address it, one of the things that I'm very conscious of with the folk that I work with and serve is making sure that they're informing me of decisions. And when we make policy, no policy should hurt the people that you serve. Included in that is we talk to people with lived experience on the Columbus and Franklin County Addiction Plan at Columbus Public Health. They sit on our subcommittees. They chair our subcommittees and tell us what it is that works. So when we did the walk-in for recovery, this is now our 4th year, we have, since its first time, we have quadrupled the number of people served. And it was all based upon people in the healthcare and harm reduction subcommittee saying, why is it that agencies, and Erika, I talk about this, so you can't get mad. Why is it that so many agencies stop taking people in after 1 o'clock? Why can I not go in after 3 o'clock? No, I don't understand what shift differential means. What I know is I'm ready to go to treatment now, and you need to let me in. I'm not going to call you at 8 o'clock in the morning. I don't have a cell phone like that. So there's all of this. So what we decided was we received a grant for the state opioid grant, and we did walk-in for recovery. And we decide on locations with the highest zip codes with incidents of overdose. And from 11 to 7 at night, which are not banker's hours, which a lot of treatment is based upon, you walk in, and it's not based upon, we're going to start you in treatment. It's, do you want to eat? Do you want to have water? Oh, by the way, we have some Narcan. So it's kind of like the bait and switch, but it's not really, because really it's building rapport with them and having a conversation. And every one of these agencies has participated in some capacity in that. I also recommend, when you have those kind of engagements, do not open a wound that you can't close before somebody walks out the door, because you're doing a lot more damage for that individual than you are helping them.
So the whole conversation about naloxone kind of brings us to this person's question. How do you counter those who think needle exchanges encourage drug use, and what arguments work? So you can say the same thing about naloxone, sort of like, how do you...
I'm gonna pass it over, but I'm gonna tell you something. I just had a chocolate bar. I'm diabetic. Look, I'm short, fat, and proud of that, like Winnie the Pooh. I had a chocolate bar.
No, whatever, you're
I was
gorgeous.
stressed out. I'm ADHD. I have depression. Nobody said to me, you're a rotten human being for eating that chocolate bar. But let somebody relapse or use another substance, we will break them down so quickly. I think the medical, they probably see it more, or even Parrish, they see it more, because we've had people, both when I was at the state and the city, that would say, I hate going back to that house. We've been at that house 3-4 times to save that person from an overdose. And I would say, how many times did you save the heart attack victim? So within our own profession, and you said this, Dr. Kauffman, we make the distinctions. So why wouldn't the general public make the distinction?
I don't know if, oh, there we go. In addition to that, so I mean, I think all these things we talk about harm reduction is to help people keep people from getting sicker, keep people from dying. So needle exchange is part of that. So again, what we're seeing on the medical side is people who are coming with severe infections, losing limbs, dying from other complications. So needle exchange, naloxone give them an opportunity to stay healthy. And I would also say, so harm reduction is about keeping people safe, and hopefully at some point they will get into recovery. The other side of harm reduction, it's a social justice movement. It is about respecting the dignity and worth of every individual we care for, right? Whether they choose to keep using drugs or not, it lets them know that we care and that we want them to be here, whether they're using or not.
I've been sitting over here quiet. Yeah, I think just the conversation, and, you know, I think first responders are uniquely positioned in that we see the best and the worst of society on a daily basis. And then, but we are members of society. We go, you know, we go back to our families, and we not only deal with these issues at work, but we see it at home. And, you know, early on in the opiate epidemic, we had conversation about what are we going to do when there's a fist fight at the kitchen table, when somebody's frustrated with somebody with substance use disorder and they're venting, and the person across from them, their child is addicted to heroin, right? I think the stigmatism, at least in our organization, we've done a lot of education with our first responders. And so many of us have been impacted personally. And as society, I mean, by show of hands, how many people in the room either have a loved one or know someone who's been impacted by substance use disorder? Yeah, that's what's going to change the stigma right there, right? It's going to be coming. You're not going to be afraid to openly talk about that. If my child had cancer and I went to the fire station, they would have a fundraiser or a parade. But if I walked in and said my kid's hooked on heroin, they probably wouldn't have talked to me 4 years ago. But now they're supporting each other. The harm reduction piece, I think, is huge. I mean, what do firefighters do better than anybody in the world besides cook chili? Fire prevention, right? Prevention, prevention, prevention. And I think that is nobody gets paid to do that work. You get paid to put somebody in treatment, but nobody's really getting paid to do prevention. And until we start to focus on that and turn the faucet off and just slow down that progression, we're going to still be in this cycle of treatment, treatment, treatment. And to all your point, you know, I have adult children. When they were in college, I was the most vulnerable is the recreational experimental drug user who isn't classified or, you know, as a substance use disorder individual, but they're experimenting and they get fentanyl, right? So that is, when you look at that vulnerable population, I think we've kind of left that out, right? Because we look at the person who we see over and over again. The needle exchange, you know, a couple years ago, I was doing a panel on WSU, and they asked, you know, how do you feel about safe station injection sites? And at the time, I just went, wow. I don't think it's a bad idea now. If you can control that safely and get somebody on the right path. But again, it's more than just that one stop. There's a lot of components that go along with that. So we are heading in the right direction. I think first responders play a vital role, but we're only as successful as our partners in the prevention piece. And then the conversation on recovery. Again, we've shifted where we're treating it more like a disease, but we're not. If I had a heart attack today and I went to the hospital and they put a stent in me, I would go through cardiac rehab, probably some physical therapy, and all this stuff for 6 months, a year down the road before they're done. But you go through treatment, you get a couple of sessions, and then they're like, yep, go figure it out on your own. Nobody's getting paid for that work. So until we fund those ends equally, we're still going to be in this battle because those folks in recovery are going to relapse.
So another question from the audience is, how can community partners like pharmacists, community health workers, et cetera, participate in supporting efforts to reduce opioid epidemic? Does anybody want to take that one?
So as I've mentioned, the CNFCAP, the addiction plan, we have a lot of partners, but within that, we have a lot of specific interventions. One thing that we know, evidence-based, is to flood the community with naloxone. flood it so that lay people can dispense it at any moment. We know that giving out fentanyl test strips, though off-label to test all drugs, can prevent an overdose. We also rely on pharmacists to know the law when it comes to what the standing order is in order for me to walk up to the pharmacy without a prescription and purchase naloxone without a script to bill it against my insurance. And I've certainly had individuals say to me, I tried to go to such and such pharmacy and they said I couldn't get it. There is a law, right? We also need lay people to understand what the Good Samaritan law is with regard to being present should a drug overdose occur, so that you can save that person's life and not worry about cleaning the scene in the cut and dipping out the back. The Good Samaritan law protects you. The other thing that I'll say is making sure that we understand all of the ancillary issues. And I'm about to put Dr. Deppen on the spot, but I have to, because we have a congenital syphilis outbreak in this community that is horrific. And it isn't just with people who may be having sex for money. These are women who are contracting syphilis and their children in the womb, right? So we have these ancillary issues that we need all sectors to know about what's going on to inform the community, and then also where the resources are that they can find. So what we're doing at Columbus Public Health, we've partnered with many agencies here to purchase 10 prevention machines, harm reduction machines, that won't just have naloxone or fentanyl test strips, but also pregnancy tests, condoms, so we can prevent that from happening, as well as making sure that we have first aid kits. Some of those who will be receiving the boxes will work through the process of making sure that there's also safe syringe exchange. But to me, the public should, and the people who work in this space, no matter what space, we need to know of all the issues that are out there, so that when I have that captive audience, I can share that bit of information with them at the time.
I just want to reply quickly. I don't think you're pointing at me because I have syphilis, so I do want to point out that that I take care of pregnant women with substance use disorder, and so we are seeing, so just like the complications we're seeing in many of the other populations, and it's not just about the substance use that we're treating, it's about their exposure to infectious diseases like syphilis, like hepatitis C. And then we're not only treating one person, but we're now treating two. And so just, doing everything we can to, I think that also gets into the grandparents raising children, but doing everything we can to support that, that birthing person in delivering a healthy baby and having the support that they need to be the parent that they want to be.
We just had a comment in the paper from a mother whose 30-year-old son died of fentanyl overdose, and she never knew he even used drugs at all. I know it's hard because a lot of these drugs, you don't think about having fentanyl in them, but are there things that people should look out for in terms of my child, my level, my husband, my daughter, whatever, might have a problem, I need to intervene or try to intervene? Are there signs? I don't know.
So I get asked this question a lot because I work in the adolescent space, and many people want to know how, one, do I talk to my child about drugs? And then two, what are warning signs? What do I do? How do I know when things are getting bad? Or I can't believe I missed all of these warning signs. I can't believe I didn't see this. And people who use substances, adolescents who use substances, come from a variety of family backgrounds. I have many adolescents who are a part of a multi-generation of people in the home who use substances. So it is a part of what is happening in that home, and is, even kind of just a part of family culture in that point. I have other adolescents who I care for, who I speak to families about, who it just comes out of left field for their parent. How could my child ever have anything like this happen to them? And, there are certain things that I always tell parents to really keep an eye out for, or to watch for, especially when you're talking about this age range, that something might be wrong. And that doesn't necessarily mean that they have a substance use disorder or they're using substances, but this means something is going on that you really need to have more conversations about. Maybe it is a bigger mental health issue that's undiagnosed that you need help for. But those things would be withdrawing away from family or friends, really withdrawing from activities that they used to love to do. So for instance, someone who used to be on the football team or who used to run track and field just stops doing those things now. Someone whose grades are failing or who is not going to school. You get a call from school that they've been truant all week and you didn't realize that, or they're not showing up for work, or their previous friend group no longer they hang out with and their friends are calling asking where they are. Things that are a departure from what their normal life has looked like. Now, many people will say, well, isn't that just regular adolescent behavior? They, go in and out of things that they're interested in to a degree, but teenagers want to be associated with their peers. They want to, a lot of them want to have these pro-social engagements. And so when you have a departure from that, that's a warning sign. Like I said, it doesn't necessarily mean that you're having a substance use problem. It could mean that you're having depression. It could mean that you're having anxiety. But what it does mean is that that should alert you to take your child or your loved one somewhere to have a screening done, to be screened for depression, to be screened for anxiety, and to be screened for a substance use. If that screening is positive, moving forward to actually seeing, is there a substance use disorder? The more you just think it will go away, the more you see, well, let me give them another week and see how they're due. Or the more you just keep thinking, maybe they're just, having a bad time right now. The longer you delay actually finding out if there's a problem and longer you delay actually getting someone help. I think that, specifically in the sphere of talking with teenagers and adolescents, and even in pediatric primary care providers, we're afraid to ask those questions because we don't know what to do if they're true. We don't know what to do when they do say, yes, Mom, I actually have been buying benzodiazepines online. Mom, I've been smoking marijuana or vaping marijuana all the time. People are afraid of what that answer is. Providers are afraid to ask those questions because they don't know what to do with those answers or how to help those kids get help. And so you have to be really identifying changes in behavior and then not be afraid to ask those hard questions.
And one thing that I would add to that is also when you're having those conversations with your children or someone you care deeply for is also be prepared for your response. Oftentimes, children or family members will be reluctant to have a discussion because they're fearful of the response. They're fearful that they'll be judged. So before you have that conversation, prepare yourself. How am I going to feel if I hear the answer yes? And how am I likely to respond to that? Because that may open or close the door to future conversation with your child or that person you care about.
I will reply to that. The time to have that conversation is not when you find drug paraphernalia in someone's room. It's not when your teenager comes home late and it appears intoxicated. Those are not the times to have those conversations because they're going to be very heated, they're going to be confrontational, and they're really just not going to be as productive as they would be if you had it at a time where both of your phones are put away, you're going to sit down and have more of a productive conversation.
I just looked at the time and I didn't realize that we're over our line, but that's okay. It was a great conversation. I do have one last question for everyone. We've been talking about a lot of bad things that are happening to folks and awareness and that sort of thing. Are there things that you see that give you hope that this community is getting that, I don't know, handle is the right word on it, but that we're having the right approaches to this crisis and that we can find solutions that will make a major impact in people's lives?
Yeah, I'll end the way I started. And what gives me hope is this panel and our community coming together. We're not working in isolation. We are working together. So that's the only way that we're going to find solutions that will improve the health of our community from every perspective, not just substance use disorder, but every perspective. And I do see that regularly in Franklin County, in Columbus. We're blessed. There's a a lot of work being done collaboratively.
I would just echo that and grateful for our community. I think there's a lot of community partners even here in the room that we need. They're not on this stage, but it's what makes our community work. I see the Kappa Foundations in the room. We have Shiloh Baptist Church, other groups, Southeast. These are those community partners. It's going to take all of us.
I would say I'm very hopeful. And, 3 years ago, I would have had that not necessarily negative, but kind of sarcastic, like, I'll always have a job. I'll always have a job. But I'm hopeful because of the numbers. When you consider we're coming out of COVID, and actually the percentage of increase annually between each year was well over 20% each year we had growth in overdose deaths. This was the first year in Columbus and Franklin County that for Franklin County residents. So I do need to clarify that. The way that we look at the number of deaths at Columbus Public Health is we look at the number of residents. We had 788 residents die in 2021. In 2020, we had 804. This is the first time in 7 years we did not have not only not a percentage of increase, we had a decrease. That's remarkable. Also, I think that people like us and these conversations are forcing us to confront that ugliness that we talked about and to take away the stigma just by having a conversation and normalizing that this, like anything else, is still a disease. But again, you mentioned partners. I don't know if she's still here. We had Birdie's Light, yes, here. Which really does a great job of going out into the community, talking to students about drugs and testing your drugs to prevent an accidental overdose. So the organizations are critical, but I am very hopeful because of these events and because we've seen the efforts of doing multiple pop-ups, going to the Arnold, going to corner stores, going to the middle of the spot and saying, hey, we're giving it out for free. Oh, we're going to give you some hand sanitizer, some mask, maybe a free lunch. That's what we were doing today. Whatever it takes to bring them in. If it saves their life, it's worth it.
I want to say the power of peers. I've heard the word recovery come from the faces and voices of all these people on this panel, and we are the hope dealers. So the fact that recovery is being recognized, that recovery is being valued. And by the way, this isn't new, but it is now. And there's so many of us that are out here that are willing and able, loud and proud, to talk about our stories and to walk alongside anyone who needs some hope, needs some connectedness, needs some realness. And yeah, someone said, we don't start with, hey, where are you in treatment? We start with, hey, do you want a cup of coffee? We start there, making people comfortable. And that gives me hope that there's more and more of us, and there's more and more of folks that are not necessarily in the recovery arena, but y'all are talking about us, and that makes me very happy.
All right, anybody else? Last call for alcohol. No, that's not it. What is another bad joke? I'm sorry.
Can I say one thing? I don't know if that would work. That's the one that works. Yeah, okay.
Terrible. I'm sorry.
I just want to say one thing because I see my OSU peeps here, and I want to give a shout out. We started this work in 2017. It seemed crazy, like we're starting the emergency department. How are we going to get people to really take seriously the opioid use disorder, the crisis? How are we going to start people on Suboxone? How are we going to do this? Well, I can tell you right now, at our one of our other bigger campus, we call it the main campus, we now have an amazing social worker who is dedicated to it, just addiction work in the emergency department, accompanied by an amazing nurse practitioner who I've never seen her take on patients with such empathy and like fully wrap herself around these patients, as well as what appears to be an incredible peer supporter who has just started in the department. And to see them work as a team, I met with them yesterday because this is a very new team. This is like a whole new dynamic, and I was so inspired. So it's changing. The hospital environment is difficult, but we can change with like amazing individuals who are really passionate about this work, and we will get there.
I tell you, I love all this hope.
I just want to end my thought with, we've talked a lot about pretty heavy stuff: overdose, death, disease, people not having access to care. But what I also see is I see people surviving, and I see people thriving, and I see people enjoying their lives. And I see that evidence-based prevention and evidence-based treatment do work. We just need more of it. And I want people to leave here knowing that there are people who are on your side, that are working so hard in order to get everyone access that they need, and to know that every day, we know it's hard. We show up every day knowing how hard the work is that we do. But what keeps us going is knowing that we can help you survive and thrive.
So maybe I'll get the last word, but you know, in 2017, when we started the REACT program, it was just going to be this little pilot program, and we were going to follow up on people with non-fatal overdoses. And to look 5 years later, what we have done and what we've accomplished with the partners and how it's evolved. We have a REACT Buddies program where we pair first responders with youth that live in at-risk environments as a prevention tool. We have a REACT alumni group that started with 2 folks in recovery that we had helped. That's well over 200 now. And in one of our last meetings with the health department, looking across the Zoom screen, we're like, we know her. She was an alumni who is now working in the treatment world. So to see that success, that's what brings me back to work every day. The support from my boss, the fire chief who's in the room, Mayor Ginther, and allowing this program to continue to grow and be funded. That's what gives me hope. And then just these great partnerships and being a part of that conversation. So thank you.
Well, I would like to thank you guys for all the hard work you do, just not today by sharing your knowledge, but also every day. I marvel at the work people who care for other people directly do, and the sacrifice you put in from your own personal lives. So thank you. Let's give them a round of applause. And also, I thank anybody in the audience who works in this arena as well. So give yourself a round of applause if that's what you do. Okay, well, I'm Amelia Robinson from the Columbus Dispatch. On behalf of the Dispatch and Dispatch.com, I thank you so much for coming tonight and for watching on social media. I also want to thank our partners, Ohio State University, the Central Ohio Hospital Council, and WOSU. Like I said before, this will be available for rewatch on our platforms, Dispatch.com, Twitter, Facebook, I said Twitter already. Google, we have Google, I think we probably have YouTube, there you go. YouTube, and also we have great stories on our website, some fantastic columns from some folks on the panel, and also some other people who live this every day at Dispatch.com. Until our next community conversation, we'll see you later. Thank you.